Hello again, it's Dr. Jaffer. Today we are starting a new chapter, and the chapter name is Periodontal Disease, starting with the first topic, which is periodontal pocket. Please subscribe to my channel HL Talent to get more videos on these subjects. Today we are going through the introduction, classification, clinical features, pathogenesis, and changes that happen on the pocket wall, especially on the root surface, and the contents of the pocket and the healing process. Normal sulcus usually is from 0.5 to 3.5 millimeter, and when there is a pathological deepening of this sulcus, the name will change to pocket, periodontal pocket, and it's the most important clinical feature of periodontal disease. And this pocket formation can occur by coronal movement of the gingival margin or the apical displacement of the gingival attachment, or combination of both. It's either there will be an increase in the size of gingiva and covering the coronal part to increase the probing depth, as in the gingival pocket, or it's caused by apical displacement of the gingival attachment, like you see it here, and forming an increased measurement of probing depth, and or a combination of both. So this is a periodontal pocket. And regarding the classification, as we talked about in the introduction, we have three major types. We have gingival pocket, suprabony, and infrabony pockets. In the gingival pocket, as we said in the introduction, there will be a coronal movement, the gingiva coronally toward the crown. There will be a coronal movement of the gingival margin. And here in the gingival pocket, there is a gingival hyperplasia covering the coronal part of the tooth, and when you are measuring with the probe, you find that there's a pocket, but this kind of pocket is not due to the destruction of the periodontal ligament and bone. It is just because of the hyperplasia of the gingival tissue, and the name of this pocket is pseudo pocket or false pocket. Well, we have periodontal pockets, which are suprabony and intrabony or infrabony pockets. The main difference in the terminology between these two is because of the junctional epithelium. Here in the suprabony, the junctional epithelium is above the crest of the alveolar bone, while in intrabony or infrabony, infra means below, the junctional epithelium is below the crest of the alveolar bone. And here's the difference between the suprabony and infrabony pockets. And in the suprabony one, the bone destruction is horizontal, while in infrabony, the bone destruction is angular or vertical. And on both of the lingual and facial surface of suprabony pockets, the periodontal ligament beneath the pocket wall follow a horizontal pattern or oblique pattern, while in infrabony pocket, both of the facial and lingual surfaces, the periodontal ligament fibers follow an angular pattern. So these are the differences between the types, and this is the classification of periodontal pockets. Regarding the clinical features, the clinical features of the pocket is the gingival wall of pocket present with various degree of bluish red discoloration, and we have a term named flaccidity. The flaccidity means the surface wall of the pocket is shiny, smooth, and there will be a pitting on pressure. When you press the tissue, there will be a pit, formation of pit on the wall of the pocket. And there will be a less frequently, and you less frequently see the gingiva which is firm and pink. You may see it, but it's less frequently seen. Also, bleeding is elicited by gently probing of the pocket wall, and when explored with the probe, the inner surface of pocket is generally painful, and in many cases, pus may be expressed by applying a digital pressure. So sometimes when you finger press it, you find a pus or exudate coming out through the pocket. And also there we may see a tooth mobility and diastema formation. So this is regarding the clinical features. The pathogenesis, as we see in this picture, when we have a bacterial aggregation, and this bacterial aggregation doesn't removed with the scaling and rotiplaning or daily oral care, oral hygiene care. So if we don't have any inhibitors, so the innate inflammatory response, including neutrophils, macrophages, will act against these antigens by secreting prostaglandins, cytokines, tumor necrosis factors, and these immune response by themselves are destructive to both bone and connective tissue or periodontal ligaments. So, for example, prostaglandin enhance the bone resorption, and matrix metalloproteinase enhance the connective tissue breakdown. So the continuous fighting between the inflammatory response, host inflammatory response, and bacterial endotoxins, it will lead to destruction of both connective tissue and bone metabolism, and this will lead to formation of a pouch or pocket formation and the loss of connective tissue and bone. So this is regarding the pathogenesis of how a pocket will be formed. The changes that happen, we have chemical changes throughout increasing of the surface of cementum, increasing of calcium, magnesium, fluorine, and phosphate. And we have cytotoxic changes when the bacteria will aggregate on the root surface. There will be excretion of endotoxins and the degeneration of the periodontal ligaments. So we have these changes: chemical changes, cytotoxic changes, structural changes. In the structural changes, when the surface of cementum is exposed to oral environment, the minerals that present in saliva, including calcium, phosphate, and etc., will be aggregated on the surface of the cementum, and it will create an area of hypermineralization. Also, root surface is exposed to oral fluids and bacterial plugs, and these fluids and plugs, including cytokines and the endotoxins in the that will be excreted by the bacteria, it will lead to proteolysis of the remnant of Sharpie's fiber. And this degeneration of Sharpie's fiber creates an area of demineralization, and subsequently leading to root caries, and the root surface will be soft and lethargy on probing, and the patient feels severe sensitivity to thermal change and sweets. And in most advanced cases, in the most severe form of degeneration, it will lead to pulp exposure. The changes that, as we talked about, the changes that happen on the root surface wall, including the deepening of pocket, destruction of collagen fibers, and inside the cementum, the end fibers of the periodontal ligaments named Sharpie's fiber, and this will be degenerated, which allow the penetration and growth of bacteria on cemento-dentinal junction and dentinal tubule. And this will lead to fragmentation and breakdown of cementum, resulting in necrotic cementum, which is covered by a mass of bacteria. So on the root surface, the morphology of the root surface of the pocket wall be covered by 5 layers. A layer of calculus, and a layer of attached plug which covers the calculus, and a zone of unattached free plugs, free bacterial aggregation, and a zone of attached epithelium. We have junctional epithelium on the tooth surface, and also an area of destroyed connective tissue apical to cemento enamel junction. So this area, the pocket wall, is a friable, weak area. It's susceptible continuously to various types of attacking by bacteria and the different factors that will affect the root surface. So this is regarding the changes, chemical, cytotoxic, structural, and the root surface morphology. We are going to the content of the plug. The plug contains debris which consists of microorganisms and their products, including enzymes, endotoxin, and metabolic products. We have calculus, as we talked about. We have pus, we have purulent exudates, we have food remnants, we have gingival crevicular fluid, and desquamated epithelial cells and leukocytes. The pocket can be detected clinically by probing, and it's not visible on radiograph unless we are using, for example, guttapercha or silver cone points, but it's most probably could be diagnosed and examined with the probe, and the probe should be used gently, not using a pressure, and inserted parallel to the long axis of the tooth, but slightly obliquely to be inserted inside the sulcus. And we are using for this purpose a periodontal probe of different designs. We have different designs. The most appropriate one, in my opinion, is a WHO probe, which have a ball of 0.5 millimeter measurements. And this is a content regarding the healing process. Complete healing process doesn't occur because of the presence of local irritants, and these local irritants will inhibit the new cell formation. Why? Because it stimulates the fluid and cellular exudates continuously until it will inhibit and degenerate the new formed cells. And the balance between the destructive and constructive changes that happen within the pocket wall, it will determine the clinical features. For example, as color, consistency, and surface texture of the pocket wall. And accordingly, the pocket wall can be either edematous, destructive, or fibrotic. In the edematous one, if inflammatory fluid and cellular exudates predominate, so the pocket wall will be more bluish red, spongy, soft, friable, with a smooth, shiny surface. But if the pocket wall is going through the constructive changes, here the newly formed cell, connective tissue cells, will predominate, and you see the pocket wall is more firm and pink. But here it's more misleading, because outside you find a pink and firm wall of pocket, but inside there is a destructive inflammatory process. So this is regarding the healing also, and this is the end of my lecture. I hope you enjoy it, and please subscribe to my channel again to get more videos. Thank you for your listening.